Good morning. Warm welcome to our IC on what's new in diagnostics. Evolution is something very important and integral part of our patient care. So we have a great set of speakers who will be covering each specialty with regards to what is new. To begin with, I invite Dr. Pratibha Devi Nivian, oculoplastic surgeon at MNI Hospital, to talk on 3D orbital imaging. I request Arul sir to please come on stage, please.
Very good morning. This is the same repetition for I think the speakers here, but anyways. So orbital fracture is not a very uncommon finding in our practice. So in patients with trauma and double vision, we should definitely ask for a health charting, diplopia charting and take a CT orbit to see for fractures. So very commonly we can see fractures like this with orbital fat entrapment and muscle entrapment sometimes, which definitely requires a treatment. So we were successfully managing orbital fractures since many decades with so many types of implant that is available in the market. So as in this patient where both anterior and posterior ledge is seen, we can very comfortably go ahead with surgery with a Med4 implant. In children with a white eye like this but a face turn and head tilt like this, children will not complain as diplopia, rather they will have a head tilt and a face turn, and the mother actually came up with complaints of face turn for this patient. We have to definitely take a CT orbit, and that shows a white blowout fracture. And in children, we prefer an osteomesh because it is biointegrable and that merges with the existing bone as the child grows. And in little more bigger fractures like this, and where there is a posterior ledge is not very defined, we put a titanium implant like this. So, but we had a lot of difficulties. We do not know the exact size of the implant, so we have to repeat the manipulation multiple times, and so there was more tissue injury which caused a delayed post-operative period, and there could be a wrong placement of the implant as well. So change is inevitable, and we have adapted changes in so many things, and 3D printed models are one such change which had happened in orbital fractures. They are nothing but they are molds to shape the implants pre-operatively, and that shaped implant is sterilized and used in the OT. So it's just an easy way of customization of implant. So how do we do that? So when we get a CT orbit, there is that's a format called DICOM format, and specifically we have to ask the radiologist for that, and that is with that format, the STL images, the 3D images are obtained, and the 3D model is designed. So the 3D model is designed like this, and once we get that, we can design our implant and plan the size and exact shape of the implant. Scenario 1, here there is a fracture in the right orbit. So they mirror the right orbit with the normal side, and we get the exact dimension of the fracture. So we get a model like this in the hand. So when we have the model in the hand, we can cut the implant exactly according to the shape and size of the fracture, and then we can autoclave and use it in the surgery next day. So in complex fracture like this, here the zygoma is fractured. So what the software does is it manually virtually reduces with superimposition, and then again it mirrors and gives STL image, and with the STL image we can get a model like this. So in this complex fractures also, we will know where all we have to put the screw, where we have to put the implant, and what type. Everything can be planned meticulously prior the surgery, and then we can go into the OR. So, and on top of this, there is something else called the patient-specific implant, like how we have the customized implant, like how we put the dough, take a measurement, paint. This is something called patient-specific implant. The previous things, we trimmed the implant, but in this, the company person trims according to the fracture size exactly, and so just we have to keep it in the place. And so what is navigation? Now, all these things are done manually. So we design, we cut the implant, and then we put it manually. But still, we do not know whether we are in the right place. So navigation will tell us where exactly we are inside the orbit. So just like a GPS tracker. So it was started for neurosurgery, but however, that has come into orbital fractures because of its guidance, intraoperative guidance. It's been used for fractures and also for apical tumors, or the tumors which are very close to nerve. So we will know how close we are to the nerve. So that is the biggest advantage of navigation. Without navigation, sometimes we might go very close to the nerve or we might even hit the nerve. So in such tumors and fractures, it has been very commonly used, but people are now trying it for other surgeries like decompression, and even lacrimal surgeries are being done. So the navigation, in navigation, there is a software and the patient data is being fed, and then there is a tracker which says where exactly we are in the orbit. There are two types, electromagnetic, optical guidance. We follow the optical guidance, and the armamentarium has an instrument console which has the display, the pointer and the tracker. So as I said, it's a GPS tracker. So the patient data is fed, the registration is done, and we planned the procedure previously. And this is the setup, like how it is being done. I have a small video um, by Dr. Preeti, courtesy. So as you see in this picture, so this particular navigation, it gives us three images. It gives a coronal, axial and sagittal. So this is the pointer. So when we do the surgery, we will know where exactly we are, whether we have placed the implant right or we have placed the implant in the maxillary sinus. So it shows clearly where exactly we are. This has been done for a fracture, but it's very helpful in apical tumors because its predictability is very good. So advantages, lesser tissue manipulation, better and easy contouring of implant, faster rehabilitation definitely. But disadvantage is very expensive. It's equal the cost of a femto machine, I guess, the machine, I guess. So probably when we think about returns, we might not be able to get it in a single specialty center. It has a long learning curve and will need multidisciplinary approach. It needs a spacious theatre to accommodate the armamentarium. So to conclude, adaptive technology in specific cases is very important, and a team approach, particularly when the fracture is complex, is very important. And this should not be forgotten. We should never forget this. We have to do a detailed visual field and an ocular examination before any intervention. That's more important than all these fancy technologies. Thank you. Thank you for the opportunity.
What date you have to send to the company ready to work up?
Only they ask for the DICOM data. That we have to specifically tell the radiologist to give the DICOM data of the CT images. So then there is some technical person who does this STL models. So if we hand over that, they will give the model. So it's just like a skull model, that's all, nothing different. They mirror the abnormal side to the normal side. So we know we will have the fracture. Every negetal fracture, we will have the fracture in that model. So now the people who have luxury of navigation can go ahead, but otherwise we can design the Medpore implant, we can cut the Medpore implant according to the shape and then sterilize it, and then we know correct and the implant can be placed there.
Thank you so much, Pratibha. So the next talk will be on optical biometry. Well, IOL power calculation formulas and biometers have been evolving really fast over the past decade or so. So why optical biometer? The main advantage of optical biometer over conventional technique or over ultrasound is it is extremely repeatable, and another major advantage is it can be delegated. You don't need a greatly skilled technician to do optical biometer, and the results in between scans or between one technician and the other is more or less predictable and reliable. Another advantage is the level of accuracy is much high and the results are far more predictable. However, optical biometric immersion scan, when it is done by an experienced good technician, can give reasonably good results provided it is not a very long eye or a short eye. Axial length between approximately 20 to 24 will give reasonably good values with our immersion scan. However, for short and long, these are not ideal, and for post refractive surgery eyes and for irregular corneas. Another major advantage is it is not just axial length that is important or needed to give good values post biometry. You need a whole other information which includes AC depth, corneal thickness, posterior decay, white to white, lens thickness. This helps us to assess the effective lens position. Formulas have undergone a rapid change ever since they started incorporating the concept of effective lens position or position where the lens is going to sit for that particular patient. It's a small video in the lens meter. We are moving a plus 20 diopter lens slightly up and down, and you can see as we move the lens up and down, the power in the lens meter keeps changing. So this is nothing but ELP, or effective lens position. And what is surprising is, for our patients in the category of axial length 22 to 24, the power variation in fact is more significant. And for myopic eyes, the power variation is not much. For a axial length of 22 diameters, an ACD error of just 0.25 will cause a power difference of about 0.4. So for these patients, the position where the lens is going to sit is very important in order to predict exact values. Swept source biometers of late are slowly taking over the previous generation biometers. Few advantages which the swept source biometer gives is, one is the telecentric keratometry, which is available with the Zeiss system. In other words, what mainly it does is, if the patient's head is slightly decentered or tilted slightly front or back, the equipment does not give false values. It has an internal nomogram where it adjusts the values and gives fairly reasonable results. The number of points where the data is obtained for our swept source biometer is high compared to the previous generation biometers. This also does extrapolation, but the number of points tested in these equipment is far higher. So the extrapolation actually does happen, but it is on a much lesser scale than the conventional equipments. Another major advantage is, this actually estimates the true K, or the keratometry value of the particular cornea, with, as I said, with less extrapolation. So these are particularly important in corneas which are not regular, previously treated corneas, post keratoplasty eyes, and most importantly post refractive surgery eyes. Previously, a couple of years back, it was still believed that Barrett's calculator was giving equally good values, but courtesy the current generation formulas, which include the Kane and the Hill RBF, the true K gives slightly more precise, better results than previous calculators. Another advantage is central topography, which was discussed 2 days back in Dr. Adith's IC. So another advantage is, you can have a rough estimate or a glimpse of any irregularities in the cornea. In the Zeiss system, we get only the central topography. With the Antirion and Atlas and other biometers, in addition to central topography, in one shot you get topography up to, I think, around 8 mm. So that also will be able to screen irregular corneas. Maybe we can diagnose PMDs and the ectasias not in the visual axis or in the pupillary area. The third advantage is, this equipment has an inbuilt OCT scan, which helps us to ensure that the value is taken exactly from the foveal pit, and it gives far more precise results, and we don't go to the parafoveal area and get irregular values. And we will also be able to catch subtle macular pathologies with the OCT scan, and we'll be able to convey to the patient and give us better results. Previously, any patient with a grade 3 or grade 4 nuclear sclerosis, dense PSC, mature cataracts, these biometers were not able to penetrate. But the SST biometers are able to penetrate even through dense cataracts and give fairly good values. The previous generation biometers had big change. They were measuring the anterior surface of the cornea using reflectivity. Because of that, when there are irregularities in the cornea, it gives false K values. With the swept source based system, actually the measurement is not done with reflectivity, it is done with swept source imaging. So maybe the role of tear film may get negated. As of now, there is not much data available to prove this. With evolution and with time, maybe the effect of tear film may get negated. There was a study which compared, results between the Zeiss IOL Master and the Antirion system. There was not much variation available. Both are equally precise, gives good values. The reason why changes happen between keratometers is, each equipment does take K values at different areas of the cornea. So what I would like to say is, if you are using an immersion biometer, it is not ideal to take values from the manual K from the IOL Master and put it into the system, because the immersion system or the contact A scan is meant for values from 3.2 mm zone. If data is taken from a topographer, SIM-K has to be taken. you cannot take data taken from the 1.7 mm zone or 1 mm zone, put into the A-scan system. We will end up with wrong values. Change is always a constant. Biometry keeps evolving. Biometry is no longer a luxury, but a basic and a necessary tool. Thank you so much. Wait, 1 minute, wait. For the next talk, I invite Arul sir, Director of Uma Eye Clinic, to share his views on multifocal ERG.
Morning. Thank you, ATHEEK, for asking me to talk about ERG. We're all used to seeing ERG pictures, particularly some squiggles come out. We send out the patient asking for ERG in specific conditions, and we don't look at the pattern. We're all not taught to study the pattern and understand what is going on. We look at the report that comes off from whoever has done it. So ERG is quite important. It can be used in regular practice. We're not limiting ourselves to only retinal practice or neuro-ophthalmology or a practice which is involved with genetic disorders, where ERG is used far more commonly. But even in a day-to-day practice, it's very, very useful. It's a composite electrical activity from photoreceptors, Miller cells, and retinal pigment epithelium. So it's a use of a pattern reversal stimuli that's been proven and accepted as a viable clinical tool. So you have got a full field ERG, you have multifocal ERG, you have focal ERG, and a pattern ERG. So pattern ERG are the ones that are most easy to do and the most easy to interpret. So there are several indications, right from looking at visual functions in infants for you to find out is the retina functioning properly, and combine it with the VEP to find out whether the pathway is functioning properly, whether the occipital lobe is functioning properly, to diagnosing progressive retinal disorders as well as even AMDs. Now we can look at even early diagnosis of glaucoma and diabetic retinopathy here. So normally you would find that when you have this kind of ERG to be done, it's kind of messy. You have to have a neutral electrode on the forehead, and you have to have a contact lens on the eye. That's quite messy and difficult. So the newer ones are the ones that you can use in our practice. That one that we are using, you have a contact electrode neutral on the forehead, and then you have it on the lid. The negative point here is that this contact has to be perfect. So you should have a gel that gives you perfect contact. 2, the skin should be dry. 3, the skin should not be too lax and loose. That also gives a problem. So in very old individuals or saggy skin, we have a pretty bitch of an issue. But then it can be overcome by meticulous application of electrodes. So you have this kind of a pattern ERG response. This is how it looks on a normal patient. So there are several protocols. The concentric stimulus protocol, contrast sensitivity protocol, both are available. This is the normal graph we look at. First thing you look at is a graph that tells you on top 2 green dots, right and left. That means the stimuli or the recording is of optimal strength. If that is yellow or red, that means the whole system is not being recorded properly. Either because the contact is not good, patient is not cooperative, or it's not been stuck properly, or the gel was not there. Then this tells you whether it's normal. One need not sit and learn all of these squiggles. And you look at also, and everything is in green, everything is fine. It goes into yellow or red, something is wrong with that particular patient. The vertical axis indicates amplitude in microvolts. Horizontal axis is the time. So if you look at the ERG waveform, you have an N35, N50, N95. That corresponds to the milliseconds. So first one is negative, second one is positive, third one is negative, the fourth one is again positive. So this is how it looks, a standard one. So let's now look at all of that. Interpretation, only, please remember on ERG, unless the retina is at least affected to 30 to 40%, ERG will not show it up. So it's going to be extremely early, but that's early enough for us. So that's what we think. When I'll come back to glaucoma and diabetic retinopathy, it can be very, very thought-provoking. So this is a healthy response, and another is an abnormal response. A negative ARG is caused by a negative large A wave, X-linked retinoschisis, congenital stationary night blindness, quinine toxicity, siderosis, melanoma associated retinopathy. Non-recordable will be seen in Leber's congenital amaurosis, retinal pigmentosa, total retinal detachment, retinal aplasia. ERG in glaucoma. This is very, very important. we all are looking at now, going away from the field, going to OCT, looking at the RNFL and the GCC. Well, we all know there is a 6 months to 9 months gap between an RNFL defect, GCC defect, before it can show up on the field. Well, the same thing, it can catch this about 2 years earlier. So properly done in a glaucoma suspect, if you see this kind of pattern, that means this is early glaucoma affecting the retina. So this will show up as RNFL defect and GCC 1 year later and show up in the field 2 years later. So it's extremely useful if done properly and followed up properly. The critical part is executing the examination in a proper way. You have to train yourself to do it or train your people to do it properly. Same, this is a glaucoma suspect. One eye is absolutely normal, other eye shows an issue. Look at the waveform itself, shows you the difference, but then you can straight away get it very, very easily. This comes with glaucoma suspect with OHT. So with the increased intraocular pressure, again, both eyes show that there is early damage. Though RNFL is fantastic. Everything is fantastic here. So this shows up almost 2 years ahead of time. So it's a useful tool. In diabetic retinopathy, again, you can catch these things very, 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 very early. But whether at that early point, you're justified in starting treatment on the patient or applying a laser on this patient, or are you going to now earmark this patient for more close follow-up over a period of time? That is left to our interpretation, what we do. So probably what we will do at this point of time, not rush into treatment, but you would probably now see this patient every 3 months or 6 months instead of seeing him once in a year. So that gives you a very, very good diagnostic, early diagnosis for all of these conditions. So contrast sensitivity ERG, if you do that, that catches diabetic retinopathy much faster than the other methods. And in optic neuropathies also, it is very, very useful. Leber's optic neuritis, you see these kind of a thing in macular dystrophy. So all of these conditions, you can have ERG giving you a diagnostic aid. So it's a clinical tool to diagnose retinal disorders, a valuable tool in diagnosing early glaucoma and DR. So this kind of easy to perform ERG is a valuable tool in a day-to-day practice, while actually if you're trying to do very advanced research work, you have to go for the higher end ERG. It's also probably about 8 times more expensive. So this is quite inexpensive, easy to use product. Thank you. The maximum time is spent on getting the electrodes properly positioned. You get that, it takes about only 5 to 10 minutes. So getting the electrode properly done, especially in an older individual, in a sweaty individual, in a person with very lax and wrinkled skin, that is a catch. So your people have to be well trained in that, and the gel should be used properly. It's very tempting to, these electrodes are expensive. It's very tempting to reuse them. But in reuse them, unless the young patient, you can't reuse it. So older individuals, better to go spend the money and have a new one for each patient.
Yes. Hi, morning. So I'm just going to brief you about the different intraoperative imaging techniques that we have today in our surgical armamentarium. So as we know, the demands of our patients, especially in cataract surgery, are constantly increasing. This intraoperative imaging can take our accuracy and precision one step further and give you an edge when performing your cataract surgery. So essentially what this does is it helps you plan your toric IOLs. It gives you an heads-up display of which axis exactly is required for you to implant your toric IOL. It will give you an marking as to where you have to place your incisions. In case you want to treat the astigmatism by placing your incision in the steep axis, it will tell you where exactly to do it. And also it can also give you an overlay of your rexus as well. So you can get a perfectly well-centered rexus, which is 5 mm, which will overlap the optic edge as well. So this is how it is. There are essentially two companies which have it right now. One is the Zeiss, other is the Alcon, both of which are comparable in nature. So we have experience with the Zeiss Callisto per se. So how this works is, again, like I said, it gives you the incision position if you wish to treat the astigmatism. Gives you a rexus overlay, so you can center the rexus, and also allows you to align your toric IOLs. So you need the IOL master to integrate the Callisto system. It takes a pictures of the patient's blood vessels and the limbus and uses this as a reference mark to get the 0-180 degrees, and allows you to align your toric IOL along the respective axis. So this is a video of the same here. As you can see, before the surgery is beginning, the Callisto machine is turned on. The yellow line will represent the 0 180 degrees, which has already been captured by the IOL Master 700. The three blue lines are there, which is where you need to align a toric IOLs. You need to align along the central blue line, which is now the 124-degree mark here. As you see here now, the surgery is about to begin. So we'll just fast forward through the steps. This is a routine phaco. So after the nucleus fragmentation and emulsification is done, it's now time for us to implant the IOL. So you implant the IOL into the bag and then you wait for the Callisto to turn on, and then you can align it along the correct axis. So you just have to align the toric marks along that blue line, the central blue line, which is now the 124-degree axis. So I can see here it's very easy for you to get that alignment done. And this alignment is quite precise. You can be spot on that this is at the 124-degree axis. The other thing it also helps is with the Rexis overlay. So as you know, especially when you're planning your toric IOLs, it's very important to have a well-centered Rexis at 5 mm. If your Rexis is not completely circular or a little decentered, this can lead to IOL tilt, and it can lead to your IOL being misaligned, and your toricity will then be altered, giving rise to suboptimal results. So this is a Rexis overlay. The inner circle is about 5 mm, outer circle is 5.5 mm. So you might think to yourself, okay, I'm an experienced surgeon, I don't need this overlay mark, I know how to make a 5 mm Rexis. But believe me, once you try this, it gives you consistent results and gives you a very, very well-centered Rexis, which will be very helpful in getting your toric IOL stable. And you can be sure that the percentage of the toric IOL from misaligning will be very less. So this is a routine phacoemulsification. I'm going to skip all of that and just go to the implantation per se. So as you see here, again the IOL is being implanted. The yellow line will be representing the 0 180 degree, and this toric IOL is being implanted at the 131-degree mark. You just have to align it along the three blue lines and ensure the toricity marks it is in the central blue line. So this is here at the end of surgery, and also you have to ensure that you evacuate the visco under the IOL to ensure that the IOL doesn't rotate in the early post-operative period. You just have to align it in the central blue line. That's about all. So at the end of surgery, you hydrate the incision and you can close up. So again, the literature is quite clear about this. I picked up some studies from very well-reputed journals from JCRS mostly. All of these studies tells us that when you compare the manual marking with the intraoperative imaging has a little lesser chance of having an IOL rotation in the early postoperative period, and you will not have that many IOL rotations. This because this manual marking is prone to human error. One is you do use these ink marks to mark it. The other is it is done via your hand. So there are chances of having a few degrees clockwise and or anti-clockwise of error. This imaging system will greatly reduce those chances. So again, these are four very well-reputed studies from well-reputed journals telling us that intraoperative imaging does give us a significant advantage. Another thing is it also has less deviation in the target-induced astigmatism when compared to the manual marking. So this was done with the Alcon system as well. So like I said, there is no real difference in the outcomes when you use the Alcon or the Zeiss system, all of which are very predictable and give you good results. So in case you are using the 3D system from the Zeiss as well, you can incorporate this into your practice. It is all well compatible with the 3D microscope. The next technology I wanted to speak about is a femtosecond laser. So as you know, this also uses as a type of imaging. It's an OCT based imaging and performs multiple scans of the eye, and all of the dimensions are displayed prior to the initiation of the laser. You can go ahead and do your LRIs, you can do your incisions, your rexes, and your nuclear fragmentation patterns as well, all of which can be modified according to the surgeon's preference. So this is just a video of the scanning. You see, you have planned an LRI for this patient now, and this is a scan done by the OCT. Scans the cornea, the anterior capsule, the posterior capsule, and here's the rexus being done, and here's the nuclear fragmentation. Typically, I would not advise you to use the incisions because the incisions made by the femtosecond laser are currently too corneal. They're not very limble, so it's a little inconvenient. So we don't really use the corneal incisions per se. Rest of it is quite routine. As you see here, the amount of power used is quite negligible, and one can easily fragment the nucleus and emulsify it with almost no effort at all. So this is the advantage of the femto. I'm just going to skip ahead now because this is quite a routine surgery. So again, the literature is quite clear about this. We know that the LRIs performed by the femtosecond laser are more predictable than manual LRIs, and they do stay for the treatment of the LRIs from the femtosecond laser do stay for a longer period of time in comparison to the manual LRIs as well. This is the Alcon Virion system, similar to the Zeiss. So it does pretty much the same thing as the Zeiss Callisto. The other thing I want to talk about is intraoperative OCT. So unfortunately, I personally do not have experience with the intraop OCT, but if you do have this technology, this is where it can help you. In case you're implanting an ICL, you can have a real-time imaging of what is happening. You can even measure the vault intraoperatively. Intraoperative OCT has found tremendous use in retinal surgeries. So this is where the most of the benefit will be gained by VR surgeons. So that you can help them guide decisions when they're performing surgeries for PDR, RD, or even membrane peeling. This is a pioneer study which says that when surgeons use the intraoperative OCT for the ERM peeling, there was an improvement in visual acuity, reduction in macular thickness, and lower recurrence rate because they're able to do it much more meticulously at better accuracy. Again, this is another one which said intraoperative OCT for VR surgeons. It confirmed and the feasibility of it and ensured that the patients had a better outcome. So again, this is for VR surgeons. And also, if you are a cornea surgeon, this also helps you to do penetrating keratoplasties. You can have a better confirmation that the graft and host junction are well adhered. Lamellar keratoplasties to ensure that the lamella is well attached to the cornea. All can be seen by intraop OCT as well. So I conclude by saying image-guided surgery assists the surgeon to perform precise steps by having an overlay of incision in the cataract, rexus size, and toric alignment as well. Flax technology uses OCT-based imaging to map the structures prior to the lens and the fragmentation. So assess both the technology to determine if the benefit is worth the investment to your practice. That's the end of my presentation. Thank you. Yeah. It follows it. It follows it. It has a tracker. Yeah. That's all.
Thank you, Dr. Atik, for this wonderful opportunity of presenting in your IC. So my talk will be on aberrometers. Aberrations are the imperfections of the eye that results in inability of the light to focus onto the retina, effectively causing a defect in the visual system. So basically, the optical aberrations are the major cause of poor vision. So especially when a patient walks in with 6/6 and not happy, most of the time this would be the reason for it. So it occurs when the light from one point after transmission through the optical system does not converge to or diverge from a single point. Any deviation of the optical system from a paraxial optics results in the aberrations. So the measurement of this is called the aberrometry. So this is a bit of a physics which says that the light rays and wavefronts are two mutually complementary approaches to the light propagation. Wavefronts are always normal, that is perpendicular to the light rays. The parallel beam of light produces a planar wavefront, whereas a converging beam produces a spherical wavefront. For a light to converge to a perfect point, the wavefront emerging from the optical system must be a perfect sphere centered on the image point. If that doesn't happen, that's called an wavefront aberration. So an aberrometry is a measurement of imperfections in the optical system, and the first ever clinically available aberrometer was a COAS by AMO. So basically, how do we analyze these aberrations? There are certain measurement metrics which can be done at the level of the pupil or at the level of the retina. When it comes to the pupillary level, it's called the Taylor series expansion, Fourier analysis, and the most commonly used Wernicke polynomials. And at the level of the retina, it would be the point spread function, Stirls ratio, modular transfer function, phase transfer function, and the optical transfer function. So this is a Wernicke polynomial. The shape of the wavefront can be analyzed by expanding it into these sets of the polynomials. So wherein the first two orders, the 0 and the first, would be a constant, the second would be the lower order, and everything after this would be the higher order aberrations. So the unit for wavefront aberration is microns or fraction of wavelength and is expressed as the root mean square RMS values. The higher the RMS value, the greater is the overall aberration for a given eye. Majority of patients have a total RMS value less than 0.3 micron for a 6 mm pupil. The pupil size is also very important when the calculation occurs. The most higher order Wernicke coefficient have a mean value that is very closer to the 0. The most important Wernicke coefficient affecting the visual quality would be the defocus, spherical aberration, coma, and the secondary astigmatism. The polynomials, as I said, the first order, second order, and all, it can be expanded to any arbitrary order if a sufficient number of measurements are made for the calculation. Currently, that's the biggest drawback for us because we could do only till the 7 orders. The spectacles can correct for only the second order aberration. That's very important clinically. So as I said, this is at the level of the retina, again same like the Wernicke polynomial. Okay, so type of barometry could be subjective or objective. Subjective is almost like absolute nowadays. It's only the objective that we are using. It has an outgoing, ingoing, and ingoing feedback. The outgoing works, I mean, like the barometers that work on the outgoing phenomenon is the Hartmann shack and the wavefront sensor. Ingoing is the Sherring's aberoscope, cross-cylinder aberoscope, and the ray tracing technique. Ingoing feedback is a spatially resolved refractometer. Shackman Shaq Hartman devices evaluate the light bounce back from the eye. That's why it's called an outgoing reflection. There are numerous lenslets focused on the reflected wavefront. If there are no optical aberration in the system, an uniform pattern of perfectly spaced dots will be seen. And if it is not, then it says the amount of aberrations. The ladder wave, Xi wave, VASCA, wave scan all works under this principle. Sharing and ray tracing aberrometry, the retinal image formed is imaged and then evaluated by a charge coupled device sensor that determine the deviation of spot from the ideal. So you have an ideal spot and there is a reflected spot that has been compared. This is the technology that's been used in the wavelight and the Schwind aberrometers. Slits ioscope is a double pass aberrometry. Basically, an infrared light scans the retina and the reflected light is measured to create a wavefront. So basically, we are doing two measurements. So that's why it's called a double pass aberrometry. The NIDAC OPD scan works on this principle. The total disadvantages of all these aberrometers are that it measures all the points at once. So there is a lot of data confusion. There could be a compromised resolution. It's a limited dynamic range, so cannot measure highly irregularized, and it is highly sensitive to noise. Coming particularly to the Hartman, it measures the reverse aberration, so it is considered to be non-physiological. Sharings need a 2D imaging of the retina. A 3D image which has been converted to 2D image can lead to a lot of additional noise and errors. Shioscopy does not measure the skew deviation, so inaccurate trefoil, quadrifoil. There's no open field fixation, so an instrument myopia can be induced in the younger adults. The aberrometers that is commercially available and that stood the test of time are the NIDAC OPD scan, COAS, iTracy, Maxwell, and the Aura. We'll skip the NIDAC and we'll move on to the iTracy, which that's a one aberrometer which is commercially available. I have no financial interest. So there are multiple parameters that could be checked with this. Basically, iTrace works well for a cataract surgery. It helps us to find the origin of aberration in an eye. It increases the premium lens success, helps in planning the toric IOL. It identifies the cause of post-operative dissatisfaction for the patient. Right. So the aberrations, the wavefront verification with the help of RSD and the wavefront values allows rapid diagnosis of both the lower order and the higher order aberration in a patient. The iTracy has got a unique feature to separate the corneal and the lenticular astigmatism. So you have the whole eye's aberration and you have the corneal aberration. When you subtract the corneal aberration from the whole eye, it says whether the internal aberration is higher or not. So the origin of aberration, whether it is from the cornea or the internal, could be identified and treated accordingly. So this is an early cataract changes. Sometimes the patient will have 6/6 vision but might not be very comfortable with the vision. Once you do it through an iTracy, it will tell the actual patient's aberration, and even if the patient has got a 6/6 vision, if the quality of vision is not good, we are justified in doing a cataract surgery for this patient. And it helps in assessing the angle kappa. We know that high angle kappa is a contraindication for implantation of premium IOLs. Choosing the right IOL, the iTracy, the aberrometers, most of the aberrometers, it gives the value of the spherical equivalent value of the patient, the corneal asphericity, the angle kappa. So with this, you can actually tailor make your IOLs and customize it for every patient. Toric IOL planning, it gives a complete planning output, and in case if the patient is not happy with the toric IOL outcome, it will give the amount of rotation that is required also. For a dissatisfied patient, this is one visual function analysis which is very good because it gives a Snellen E simulation analysis, which can actually give you an idea about the potential visual complaints of what the patient is telling to you. You can assess the contrast sensitivity, as I said, like post-op assessment of the IOL tint and centration. And the most important thing is the intraoperative aberrometry, and which is the advanced innovation that's happening now, which can be attached to any of the microscopes. It can actually do measurement both in the pseudophakic and the aphakic measurement. Using the aphakic measurement as a primary data point, the device provides guidance on IOL power selection after your surgery is over, especially in a post-refractive surgery eyes. Intraoperatively, you can refine the IOL power and then implant so that the IOL power is perfectly calculated for the patient, and also for the orientation of the toric IOLs when it comes to a post-refractive surgery eye. And this is Halos is the most advanced one. The advantage is that it monitors and confirms accuracy throughout the procedure. It's a real-time imaging of the eye. So in spite of the widespread use, the application of wavefront technology is still at an early stage. It's mostly a theoretical one now. In the future, this technology has enormous potential to alter our way of thinking about the visual function, refractive error, and their corrections also. Thank you.
Okay, good morning. Let's have a quick look into what's new in OCT. I have no financial interest in any of the products that I will be discussing now. For the past 2 decades, we have seen tremendous development in the field of posterior segment imaging, especially OCT, which started with time domain, now spectral, then the swept source and the octa. So the octa, when it was first new to us, it came in the form of OptoView AngioView, which had a 3 into 3 mm slab and a 6 into 6 mm slab. But then came the wide field OCT or octa, which was able to cover 12 into 9 mm scan in the name of Avanti or Spectralis OCT Plus, which can cover up to 10 lakh data points at the rate of 70,000 A scan per second. But still we need ultra wide field imaging because we know the standard ETDRS can cover only 30% of the rotal retina, and now we know most of the retinal lesions can be located outside the ETDRS field. And then came the need for ultra wide field OCT, which is now available, or the octa, which is now available with the Silverstone swept source or the Zeiss Plex Elite 9000 and the Mirante from Nidec, and they all have to have an extra lens to capture the ultra wide field imaging. So this ultra wide field imaging can actually give the entire 200 degree of the posterior segment, and also it can take up to 23 mm scan starting from the vitreous to the corneoscleral junction, and also we can navigate and take the OCT across any area of interest along the periphery. So now we can know about the peripheral pathologies also very well. The handheld OCT is actually not new to us, but anyway, it has been available with Leica Envisu. The handheld probe weighs only 1.5 kg. This is possible by using the micro electromechanical scanning mirror called the MEMS, and it has a 1.3 meter flexible cable. So this can be used in ICU or in a pediatric setup, and this gives an image that is in par with the conventional OCT. This is the macula scan and the ASOCT, and this is maybe it might be available in a year or so, which is supposed to be the tiniest OCT called the pencil OCT, that is been developed by the Roweck Germany, still awaiting for approval. It has a scanning system and a docking system, and it's supposed to be in the form of a pocket carrying mission. And next is the home OCT. Because of the increasing demand for the increasing macular pathologies and the need for constant monitoring, something called as the home OCT has been developed, in which the OCT can be given to the patient himself. They themselves can take the OCT with a short training, and these images in the self OCT, the images are actually exported to the ophthalmologist or the trained person who will analyze the image. And if you see in this row, this is the conventional OCT, and these are the OCT taken by the home OCT. And the Notal home OCT is already available in the market, and they say it is costing around $1,000. And this has a very short learning curve. The patient can take OCT by himself, and the results need not be interpreted by the ophthalmologist. They have a software called the NOVA, that is the Notal OCT analyzer, which can show the presence of intraocular or subretinal fluid, mainly used in the AMD patients. And because already intraoperative OCT has covered by Adit, I'll just skip this one. So there is something called the binocular OCT. This is still in prototype. It uses the swept source OCT by incorporating the VISL technology, that is the vertical cavity surface emitting laser. It can be used for binocular simultaneous testing. It is self-operated and also used for pupillary examination and strabismus. This is the binocular OCT. At the same time, the patient can be presented with various image sizes. So simultaneously, the visual acuity can also be tested, and it can the strabismus or the pupillary responses can also be measured in binocular OCT. Next is the VISTA, called the variable interscans time analysis. This is again a swept source OCT. That is a software algorithm. This is still not available in the market, but this is shown to show the blood flow in the posterior macula. So this, what it does is it takes repeated B scans at 1.5 and 3 milliseconds interval at each point, and with the difference in these flow, it can show the blood flow rate. The area with the red has a good blood flow, whereas this one has a slower blood flow. This is an area of geographic atrophy with the OCT NFAS image and the Octa NFAS image. And if we see, this area of retinal blood flow is, it is more decreased than what is seen clinically. So this patient can have a progressive atrophy in future. So this is how it is utilized. And the Octa can also be incorporated along with the microperimeter. So this MP3 microperimeter software can be integrated with Mirante. And this is the microperimeter taking the central 8-degree microperimetry, and this is the Octa image. So the one-on-one is getting imported, and the software used is the Nidex Navis X platform. So it shows the point-to-point structural as well as the functional overview of the macula. Something called as retromodern OCT, which is again not very new, but it uses the CSLO technology with infrared lasers. And what happens is that we know that this is the confocal, the reflected light is passed through the center. Indirect mode is something called the refracted light is passed through the paracentral one. In retro mode, what they use is the laterally deviated light. How it is useful in practice is that this retro mode can actually show us the lesion more clearly or in a more elevated forms. So this is the PCV lesion. If you see, this is the FFA one, and this is the ICG pictures. This is the retro mode image. This is the right lateral and this is the left lateral. So we can actually visualize the lesions even without the help of angiogram. So still it doesn't show whether it's active or not. It can be used only with conjunction with other imaging modalities. And this is again and ultra wide field imaging retro mode vision. These are the nothing but the soft drusen's, and interestingly we can see that the lesions are also present in the periphery. And last one is the adaptive optics in OCT. Adaptive optics is nothing but using the wavefront sensor in the reflected light, and it is said to give more histological picture of the human retina, and especially used for the studying the cones. And this has been adapted in something called as the optoretinography, which is nothing but it shows the function of each and individual cones and rods wherever we wanted to take the image. And Altris A algorithm, the A algorithm is now also available with the OCT, which is again currently also in the market. And this has been integrated with the Hewitt's H OCT, but it's also these images, this software can be used for any of the OCTs. And this is said to be 91.3% accurate as well, and it can detect up to 30 retinal pathologies. Thank you.
Good morning. Thank you, Dr. ATHEEK, for giving me this opportunity. Yes, so ocular surface analysis. So we have to know the ocular surface is like the skin, exposed to all wear and tear, weather, humidity, temperature, injuries, harsh chemicals. So ocular surface of the eye is also like that. It is comprised of cornea, conjunctiva, the lacrimal gland, lids, and the preocular tear film. So dry eye is defined according to its like multifactorial disease of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear instability, hyperosmolarity, ocular surface inflammation, damage, and neurosensory abnormalities play etiological. So, this multiple factors. So, increased osmolarity of the tear film, inflammation, loss of goblet cells, damage to the surface cells, tear film instability, and excessive evaporation from the ocular surface. All this causes an ocular surface disorder. So how do we evaluate these ocular surface? So four main things we have to do is like ocular surface analysis occurs when the conditions alter the protection, composition, or distribution of the preocular tear film. So you have to first assess the tear volume, tear film stability, tear film integrity, and other laboratory investigation supportive for that. So to start with the tear volume assessment, we can do a Schimmer's test 1 or Schimmer's 2 with or without topical anesthesia. Anything more than 10 is normal. So we have to grade according to mild, moderate, and dry eye according to the millimeters of tear volume. Next, tear meniscus assessment is a normal thing. We can look on the slit lamp observed in the fluorescent dye after instilling fluorescent dye. Normal height is around 0.2 to 0.5. Anything less than 0.2 is significant. How do you measure the tear film integrity? You have to stain the cornea with the fluorescent or the conjunctiva with lysamine green and rose bengal. According to the rose bengal staining, the intensity and location of staining in the conjunctiva is taken into consideration and graded accordingly. According to National Eye Institute grading, the cornea, the fluorescent staining anything more than 3, and the conjunctival rose Bengal staining anything more than 3 is also significant of a dry eye. We can use a Efron scaling, which according to that we can grade the ocular surface. Tear film stability. How do we measure the tear film stability? Normal by fluorescent breakup time. So it is the normally anything more than 10 seconds is normal grade. The tear film is more stable. Anything lesser than that is the tear film is unstable. There is a non-invasive tear film breakup time we can use, which can be done using a grid or a placidose disc images. How do we measure the tear integrity? Integrities can be measured by interferometry, that is the lipid layer analysis, which gives color-coded interferences. According to that, we can see the tears uniformly blue in color, which less nanometer thick thing is like a normal eye. As is the dry eye and the lipid layer thickness increases, the intensity of the color and the nanometer thickness increases from grade 1 to grade 4. Next comes the tear scope. We can assess the lipid layer thickness in order of increasing thickness and visibility, and it is great. It appears as pattern as open meshwork, tight meshwork, or waves or amorphous patterns, and there is also color-coded images. We have an ocular surface which can be slit lamp mountable or a portable device which measures the lipid layer thickness, interferometry, non-invasive breakup time, tear meniscus height, meobobinography, white to white, blepharitis, demodex, and the bulbar redness, and use a constant international grading scale, and according to that define the dry eye as mild, moderate, and severe. Next, tear osmolarity. It can be tested normally using a eye pen or a normal tear osmolarity test, which is usually kept in the lower lid. With the capillary action, it absorbs the tear. And tear osmolarity, anything up 300 is milliosmoles is normal. A value greater than 300 milliosmoles is suggestive of dry eye. 300 to 320 mild, 320 to 340 moderate, and anything more than 340 is severe dry eye. The other things are confocal microscopy. It helps to detect changes in the corneal epithelium, immune system or inflammatory cells, or corneal nerve damage, keratocytes, meibomian gland structure. All this can be detected at cellular level. Corneal topography can show an irregular bias in the OST. Phenol red test to test the pH of the tear film. Aberrometry to assess higher order aberrations, which can be due to a tear film instability. Corneal aesthesiometer is also done because neurosensory mode also plays an important role in OSD. The other test which can be done is ocular protection index, is the time tear film breakup time in seconds divided by the interblink intervals. So you have to know the blink ratio also, which is important in ocular surface analysis. Other things are like closed chamber infrared thermometry, which can measure the temperature in the eye by closing and opening time. It's around 0.10 centigrade. In the dry eye, there is no change in the temperature. Closed chamber humidity of the eye can also be measured in relative humidity index. As such, it is like the closed chamber applied to the eye humidity is measured with eyes closed, and then for 5 seconds, open the eye and measure. The other tests are we can use a meibomian gland imaging, measure the lipid layer thickness and the blink dynamics. So we can assess the meibomian gland according to the structure, normal gland structure or gland dropouts. We can use that to assess a meibomian scale according to the distribution of the gland, degree 0 to degree 4, according to the degree of meibomian gland loss. Sjögren's test is important to assess Sjögren's syndrome. Lactoferrin test is decreased lactoferrin in aqueous tear production. Inflammatory dry eye is helped to detect inflammatory dry eye dosage in the matrix metalloprotein 9 assay. So we can treat the OSD with the anti-inflammatory therapy, and normally an OSDA score is very helpful in the outpatient department. So we can grade as dry, moderate or severe dry eye. And other tests are tear mucin, qualitative mucus assay, lactoferrin measurement, Ferning test, conjunctival or biopsy, lacrimal salivary gland biopsy. Lots of tests, impression cytology in nasolacrimal reflex, antibodies and tear protein. So all this, the ocular surface is important because however best eye surgery we do and give a very good vision, the quality and the comfort of the patient is very important. So pre-operatively, please do a proper examination, proper history, and rule out the dry eye disorder and give them a simple lubricating or preservative-free eye drop, which will give them a better quality of vision. Thank you.